I'm Dr. Raymond J. I'm a spine surgeon with Atlanta Brain and Spine Care. I'd like to thank you again for joining us in this case debate series. It's hosted by NuVasive. I'd like to thank them as our sponsor. What we do is to listen to our peers go head to head, share their philosophies about procedural approaches and the application of new technologies. This series, as you know, features a wide range of topics. So with that, I'd like to really kick off an exciting debate, and I'm really anxious to hear these guys' opinions as I struggle with this. The title of the debate today is Thoracolumbar Procedures, Direct versus Indirect Decompression. So here's a kicker today. We have Dr. Ray Ha and then Dr. Alex Thomas. Ray Ha is a very talented orthopedic surgeon and assistant professor of clinical orthopedic surgery at the Keck School of Medicine at USC. And Ray, our orthopedic surgeon, is actually taking the side of direct decompression. Whereas Alex is a neurosurgeon, Atlantic neurosurgical and spine specialist. And Dr. Thomas is out of Wilmington, North Carolina. And Dr. Thomas, the neurosurgeon, is taking the side of indirect decompression. It's almost like they've switched sides here. So here's what's fascinating to me. I'm a classically trained neurosurgeon, did an orthopedic fellowship. And traditionally, neurosurgeons would rely upon direct decompression. And traditionally, orthopedists would rely upon more indirect decompression. That's why years ago, if you look at A-lifts, anterior procedures were done primarily by orthopedic surgeons. If you look at cervical spine surgery, they talked about indirect decompression with graft height restoration, and neurosurgeons talked about removing bone spurs. So with that, let's kick it off. Gentlemen, have at it.
Well, thanks so much, Dr. Haid. Today, I'm going to be taking the side of direct decompression in thoracolumbar procedures. I open with a case of my own. Nobody likes to show their own complications. This is back in the day when I was doing, two-position 360 front back, and you can see 4-to-1 degeneration, spondylosis, with ultimately significant stenosis, primarily left-sided. In this patient, we relied on indirect decompression. Unfortunately, you can see that the supraarticular process from the translation and perhaps a little bit of the facet being locked has resulted in actually worsening of the foraminal stenosis at L5-1. And for this patient, unfortunately, although we observed him postoperatively, he really had pretty severe pain and required a take back to the operating room, an unintended take back for revision, laminotomy, and fascectomy. And so, my mentors told me, and I'm going to take this case, that, this is spine surgery. This is not highway robbery. We're not trying to get away with something here. And, there are certainly cases in which I think that indirect decompression works, and I'm a true believer in it. I think the problem is identifying those who are not going to respond favorably and trying to minimize the percentage of patients who need a take-back. So this was a case of mine, a 65-year-old female who had low back pain, multi-level radic, primarily anterior thigh and some medial shin pain. She had a little bit of a weak quad on the right, was buckling a bit, but really severe radicular pain. On her imaging, you can see degenerative curve, trace retrolisthesis L3-4 and aneurysthesis on L4-5. You can see that from asymmetric disc height collapse and spondylosis that she has developed foraminal stenosis and fairly significant central stenosis. Her preoperative long films demonstrated fairly reasonable balance. She's maybe a bit shifted to the right, but overall, she's not a patient at risk for alignment, in my view, malalignment, that is. She has a good SVA. Her lumbar lordosis matches a pretty average range PI. And so for this person, my goal primarily is for decompression as well as fractional curve correction. I wanted to limit the extent of surgery for her. She's a bit frail. Ultimately decided on L3-4 and L4-5 XLIF. And in the lateral position, performed laminoforaminotomies and fascectomies at L3-4 and L4-5 in the lateral position again with the mass retractors, which is a pedicle screw-based retractor system for the MIS TLIF. Estimated blood loss 300. Her length of stay was 3 days, although she did clear PT postoperative day 1. It was more a bit of a social issue for her for discharge. If you take a look, the next slide demonstrates actually intraoperative CT scan navigation post laminectomies. You can see that the more stenotic level, L4-5, she's been well decompressed. There's actual contralateral undercutting and decompression. And the L3-4 we didn't do as much, did more of a facetectomy to address the foraminal stenosis. Her postoperative imaging demonstrates good height restoration. One note there is that, when it's not an alignment case for me, I really try to get the graft a little more posterior because I think it will help with foraminal height. I know I'm coupling this with the decompression, but for me, in a high-risk patient with a facet overgrowth, fairly severe stenosis, I want to give it kind of the belt and suspenders and ensure she has a good outcome. Now, this is her final films. I just saw her recently. She's about 1.5 years out now. She's doing very well. ODI is 20% down from up in the 60s or 70s, I believe. And she's off all narcotics. She was on about 4 to 6 Norcos before surgery. The main thing that I want to highlight with this case is that, the question of whether you can rely completely on your disc-based distraction to treat various pathologies. And I think that the 3 things that worried me about her case, primarily she had rest pain. Even though she sat down, we sent her through some aquatic therapy. Even in the pool, she would still have a fairly significant radiculopathy. And I was worried about that. You certainly have seen published series that failure of relief with mechanical unloading of the spine may be a risk factor for failure of indirect decompression. Some of her radiographic features, which I was a bit worried about, were her fairly significant stenosis, particularly at the L4-5 level, as well as a substantial amount of facet hypertrophy, particularly again on the concavity. And so for those reasons, elected to do both indirect and direct decompression. The second case highlights a little bit of a different issue. This was a 61-year-old male. He had low back and left leg pain, moderate symptoms and moderate disability. He had a previous L4-5 microdiscectomy, but failed to improve. Here you can see his radiographs. You see fairly advanced spondylotic changes throughout the entire spine. Again, fairly well balanced. He has a grade 1 L5S1 spondylolisthesis and asymmetric disc collapse at L4-5. And what this resulted in was a substantial left-sided neuroforaminal stenosis at both these levels. And you can see on his axial MRIs that his spinal canal is patent. I'm not worried about central stenosis. But on his CT imaging, you can see that there really is substantial overgrowth of the facet at L4-5. You can also see that there's that posterior end plate spur coming back into the foramen. And for me, as I look at that, I can imagine how, with an indirect decompression, you're not really sure exactly where you are putting that spur in relation to that nerve root. And if you look, interestingly, at the L5-S1 level, the SAP of S1 is essentially not present. And for me, that makes it less worrisome. If I'm doing a height restoration, there's not really any osseous stenosis that could potentially result in persistent radiculopathy. So for this patient, we did a single position XA lift from L4 to S1. A left-sided L4-5 lamina foraminotomy, again doing a selected and targeted direct decompression for an area I felt that may have a problem if we did indirect only. The next film is kind of cool. What you can see to the right on the pedicle screws, you can see the retractor system in place. You can see on the left, we've already done the L5-S1 A lift, but the access surgeon is actually repositioning the retractors as I'm doing the decompression, and I have some clinical images of that. So really doesn't add all that much in terms of timing, depending on the circumstance, if you really feel that it is needed. The final postoperative images, you can see nice height restoration. Patient did very well. Again, not an alignment procedure, so I wasn't going for very large cage. If I'm to really self-critique, I could see that there's probably some end plate violation, perhaps at L4-5, and we could have put in a bit of a larger cage and get more indirect decompression. But that's also another point to bring up. We're not operating on healthy young patients all the time, and if bone quality is poor and you either subside intra-op or post-operatively, which many do, that's where your indirect is going to fail. I mean, you're really relying on perfect technical proficiency as well as the host's ability of the bone to support that indirect decompression. The post-operative imaging you see here, we got an opportunistic CT, and you can see essentially this was not a laminotomy, right? This was just a facetectomy to address that superior articular process, and you can see how that is nicely opened up, and the patient did very well. He was discharged in 1 day. Nice improvement in outcome scores. He's about 6 months out and back to all activities. So again, the full disclosure, I do believe in indirect decompression. I think it's well established in the literature, but most series do accept the failure rate requiring return to the OR, and that may be 2 to 3% for some centers, but some series also have reported up to 60%. At the end of the day, it's may turn out okay, and I think all of us who do indirect decompression often have these I need to have faith moments. A patient has a really hot radiculitis after surgery, and that's the reason why you went in. It's sometimes a little frustrating to have to wait and have patience. And I think that there's a goal that we go in for. I think decompression of the nerve root, and I think again, oftentimes this can be done with indirect decompression. However, we know there's a failure rate, and the ideal really in this situation is not to say, well, we only have one tool in our tool bag. We can only do indirect decompression. The ideal is to identify the high risk or clinical or radiographic factors which are going to make us believe that a selected direct decompression to enhance our other procedure may be more beneficial and reduce the morbidity of reoperation for these patients.
So I'm going to go ahead and get started. Those were great cases, Ray. So again, my name is Alex Thomas. I am a neurosurgeon in Wilmington, North Carolina. I am going to argue on the side of indirect decompression, and it is not lost on me that the neurosurgeon is taking the position in favor of indirect decompression, while the orthopedic surgeon is arguing for direct neural compression. That's not lost on me. I appreciate the irony. But I think getting back to what you said, Ray, I think you're right. You mentioned this leap of faith and taking these things on faith that this is going to work. And I think hopefully as I move through this portion of the talk, I can kind of convince you that, yes, you need to kind of prove to yourself that this works, and in the end, it benefits the patient. So let's go on to my case. And so the first case that I have is a 43-year-old female, slender, active nurse here in our CV ICU. Several years of radiating leg pain into the right leg and top of the foot, and she presented to us with the partial foot drop. She was okay when she was sitting, but as soon as she stood up to start to do any work or exercise, she would get severe pain. The next slide shows her preoperative MRI, a sagittal and axial T2 image, shows a near grade 2 spondylolisthesis with severe central stenosis. I would say this is grade 2. I think I pronounced that right. I never knew how to pronounce that. Grade 2 central stenosis in the setting of that grade 2 spondy. So someone presents with a foot drop and stenosis like this, I mean, that's pretty nerve-wracking. And I think it's important to note that I didn't get to this point here in this argument overnight. It took me several years to get to this point. So please understand that caveat. We did a single position A-lift in the lateral position with percutaneous pedicle screw fixation. I didn't present her pre-op spinal parameters, but she had a high PI, and it took us a little bit longer than average. It took us about 2 hours if you look at the final case statistics on the next slide. And that mainly had to do with dealing with that high PI and getting the spacer in. But immediately when she woke up and started walking, we get all of our patients up walking the day up. Immediately when she got up and started walking, she had resolution of that right leg pain. And of course, the foot weakness persisted a little bit, but I knew once we'd gotten rid of that leg pain, I felt comfortable that we'd address the problem. And thankfully, by 6 months, her foot strength is back to normal, and she has no pain at a year, which is always good when you have the hospital employee happy with your work. The next patient, another very typical patient that we would use indirect decompression for. This is a 72-year-old female, a little bit higher BMI. She presents with back and right leg pain for about 2 years. She failed the standard conservative management. And again, pain worse when she's up and about and a little bit better with rest. Imaging shows a grade 1, the preoperative MRI on the next slide shows a grade 1 spondylolisthesis with severe lateral recess stenosis and maybe a right-sided facet cyst there responsible for her acute deterioration. This is another patient on the next slide. Here's a pre and post-operative comparison. This is another patient that we did a single position strategy for without direct decompression, L4-5 X-lift with percutaneous pedicle screw fixation. If you look at the next slide, the final case statistics, you see an operative time of 60 minutes. And that's the sort of efficiency that you can get when you eliminate that direct decompression. And she had immediate resolution of that right leg pain. Some of her back pain persisted, obviously, but that got better in the coming months. So the question is, when you think about lateral single position surgery, what is the goal of that? What are we trying to achieve? And of course, Ray, you hit on this. Obviously, the goal is neural compression, correction of deformity, achieving a fusion, but you really want to maximize the efficiency of your procedure to get that patient out of the operating room as fast as possible so that you minimize the risk to the patient. And I understand your point about, well, yeah, Alex, there's risk in potentially having to bring the patient back to the operating room if you fail direct decompression, but we have to balance the risk of taking the time, and not to mention the extra risk of doing a direct decompression with that very small risk of actually having to bring the patient back. And so I think understanding that point is the crux here. So this is data that I was going to present at Solus that obviously is not going to happen now. This is data from the past 2 years in our patients. Over 200 patients collected in that, followed in that time frame. 129 patients underwent X-lift at L4-5 or higher, and then 79 patients underwent A-lift in the lateral position at 5-1 plus or minus an X-lift at higher levels. And you see all comers less than 3% failure of indirect decompression. And that includes the patients like you mentioned in your talk, the patients with the severe facet arthropathy. Greg Mallam down in Australia and others have shown that perhaps facet arthropathy really isn't a contraindication to trying to achieve indirect decompression. It also is irrespective of the severity of the central stenosis. Here you have another case of a grade D central stenosis from severe buckling and hypertrophy of the ligament of flavum. This patient, she's a 72-year-old female, underwent a 3-level X-lift. She actually had, you can barely see it here on this post-op sagittal, but she had a small disc herniation at 5-1 that required us to get a post-operative MRI. And I was shocked at how dramatic of an improvement that intervertebral spacer gets you. And the Japanese are actually doing some really fascinating studies looking at long-term, and I mean 10 years delayed MRIs that show not only do you get that stretching of the ligamentum flavum, but it actually shrinks once you halt the inflammation there with the stabilization. And even facet cysts, these days we don't even directly resect facet cysts. This is a 70-year-old female. She would not believe me that the cyst was gone, even though her leg pain was gone after surgery, so she made me repeat the MRI. So again, we have to balance the risk. So the question is, you're probably going to point out, and you're going to jump on this. I'm going to beat you to the punch, Ray. Why did the ones fail? And so why did that 3% fail? And it's really not because of facet arthropathy, not because of a facet cyst or ligamentum severity of central stenosis. It's because I screwed up the case. I didn't achieve the goal of the case. So in this is a guy, 70-year-old guy, who underwent an L2 to S1 in single position. He presented with a right side of radiculopathy. He came out of it with a right side of radiculopathy. And what you see here is that not only did I not reduce the spondy at L5S1, I locked it in place and then added some height with the spacer, so I added even more tension to that L5 nerve root. And he failed, and I had to take him back actually sooner than I would have in normal cases. The next case shows, again, the importance of executing the case correctly. This is a 70-year-old guy who had a mobile spondy at 4-5 and neurogenic claudication secondary to severe stenosis. And look what I did with the cage there. I made a mistake with my box cutter and violated the end plate, and I got subsidence, and this guy failed, and I had to take him back. So it's really those cases. So to Ray's point, this guy had unrecognized osteoporosis. That might be something that you keep an eye on when you're considering doing this. So Ray's out there. He can do this really slick lateral decompression, that laminoforaminotomy in the lateral position. And if anybody out there has tried this, you understand what kind of respect that deserves, because that is not an easy thing to do. But it takes time. Even someone as facile as Ray, it adds time to the procedure. And even if that's only a half hour, why would you even add that? Why would you add that time if you probably really didn't need to? And even someone as fast, Ray is facile, he can do that decompression in the lateral position. But for the vast majority of surgeons out there, the need for a direct decompression requires a flip to the prone position. So not only are you taking the time for the decompression, but you're also taking time for that flip. So it ends up being, nearly perhaps even an hour of extra time. And so what about other risks of doing a direct decompression? Now, of course, Ray's going to tell you he doesn't get any CSF leaks, and I believe him, but the rest of us do. If you look at the rate of incidental durotomy during spine surgery, lumbar spine surgery, this is a Japanese kind of review of, not a review, a series of over 1,000 patients, and they report in their introduction a rate in the literature of up to 18% rate of durotomy. Now, in this series, is only about 4 to 5%, but still, that's significant. And then lastly, time is money. We've all kind of joked about the cost of 1 minute of OR time. There is actually one study out there that looks at this. They came up with a number of $83 a minute for a lumbar fusion. So if you're adding an hour of extra OR time, that's nearly $5,000. That should matter to people. I know it doesn't matter to everybody, and maybe Ray, he lives down there in LA in a sports car on Rodeo Drive. He doesn't have to worry about resources, but a lot of people do. So I think in summary, forget all that. Just take the time to prove to yourself that you can believe in indirect decompression. I didn't get there overnight. I don't expect others out there to get there either, but just with time, I think you will prove it to yourself. Start with straightforward cases. Maybe start with cases that have minimal pre-op disc height. A lot of the literature shows that the more you can achieve in terms of disc height restoration, the more successful you'll be. Don't start with those cases with severe stenosis. And like we said, be careful with osteoporosis. And Ray alluded to this too. Listen to what your patient is telling you. He's right. Greg Mundis and Dr. Eastlack had a published study about the importance of pain at rest. So you should be careful. I think it's still doable, but be careful and just take the leap. Prove it to yourself. Once you begin to embrace that indirect decompression, you won't believe what you will accomplish in your practice in terms of efficiency. So thanks. I open it up to you, Ray, to attack me for anything that I've said.
And that was a great presentation. I mean, I think, Alex, to be fair, I'm probably, 2-3 years behind you in my experience with indirect decompression. I think there is absolutely a development that happens, and seeing those cases improving to yourself, and identifying patients which are maybe have a higher factors likely to predict successful indirect decompression. Let me ask you this, as you made that evolution in your own practice, what are some things which still stick out to you in your patients as you're seeing them that maybe make you say, hey, on this one, we're actually not going to do indirect only?
I think I still would get really nervous about obviously locked facet, so that's one of them. If the foraminal volume is just locked, I think I'd still get really nervous about really large facet cysts. I mean, it's hard to explain to the patient that you didn't take the facet cyst out when that's the reason that they came in. So I still get nervous about that, but that makes me think of another point, and I'm sure you do this too. I really have a frank conversation with the patient about indirect decompression. I say, look, here's what our data shows. It's about a 3% risk that just using the spacer to quote unquote stretch things out isn't going to be enough, and I have to bring you back in a couple months for a second stage. But here's the risk of me actually drilling around your nerve roots in your thecal sac. And as soon as they hear that, they say, oh yeah, you know what? I get it. And so the patients like to be involved in that decision making. I've found in my clinic. So they understand that notion. I think we may not give them enough credit when it comes to their ability to understand direct versus indirect decompression. So yeah, right. I get it. There are clearly cases where it doesn't work. I have failures. But it seems like as I've gotten more, I've bought into this notion of single position surgery, I've gotten bolder in terms of what I will try to get away with indirect decompression. And I don't know if that's the right approach. I appreciate what your mentors say, that maybe that's not the right thing to do, is to try to get away with something. But I weigh that, again, I try to balance the risks of, the likelihood of me getting away with it versus the risks of extra time in the OR and things like that. So I get it. It's not crystal clear.
What's interesting, Alex, is, the first time that I learned lateral single position surgery and was, thinking about incorporating into my practice, one of the holdups for me was exactly this, like, can I accomplish decompression in somebody who needs it and still maintain some of the efficiency by the single position surgery? And in fact, it wasn't until I kind of did some proof of concept cases for direct decompression that started to build up my confidence for, increasing my indications on indirect. So it's kind of having that tool and being able to be time efficient for patients and still offer a decompression when I feel, really do feel they need it, which has allowed me to kind of expand the indications and have more comfort with the indirect work. I think for me, the things that I really still look at in my clinic, and I completely agree about involving the patient in the decision. I still worry about rest pain. I worry about bone quality and osteoporosis. Severe stenosis, I'm still a bit hesitant on. I've had a few cases where I feel comfortable in that case. But really, it's kind of the osseous changes. If there's posterior end plate spur, big hook-shaped facet from remodeling, if the SAP is kind of hooked into the foramen. And that kind of, as I look at your data, which is awesome, I noticed that the L5S1 versus the L4-5 had almost a 2 times rate of needing decompression.
Mm-hmm. Yep.
I have some thoughts about that. Do you think that it's because at 5-1 you're really trying to get a lot of alignment correction? I mean, you're really going for lordosis, and in some ways you're kind of battling competing interests there?
I think that's a great point. I mean, I think that's always the battle, right? You want to get that. I'm so committed to the notion of indirect decompression. Am I maybe sacrificing some lordosis in the spacer? I think it would be interesting to track a large series of these cases, patients who either did or did not fail indirect decompression, and then look at the angulation of the cage that was used. Does it matter? Some of the studies that I've seen, it doesn't suggest that it matters, but it has to, right? I mean, that's the only explanation, because you're right. I mean, it's almost twice as high, the rate of failure of indirect decompression at 5-1. And I think it's because you're trying to get that angulation and maybe don't get enough posterior disc height restoration.
Yeah, that's what I would think. I mean, I would say just anecdotally, I can't give the data, but most of my failures of indirect have been at 5-1, and that's food for thought, at least.
Yeah, do you think it has to do with the SAP of S1? I mean, I think there's some of the morphological changes too. It's at least anecdotally, the post-op CTs that I look at, it just doesn't seem like you get as gnarly of a bony foraminal stenosis at 4-5 as you do at 5-1. That's always interesting to me.
Yeah, I do think it is. I think it's, we put in a cage which fits. We sometimes have competing goals of indirect decompression from the cage versus, alignment restoration. And, you put in hyperlordotic cages in deformity correction, and you need to be careful about what you do in the foramen, I think. So I don't have a great sense of it. I do know that because of some of my failures, I'm still trying to figure out, what are the best patients? What are the criteria by which I make this indirect versus direct decision?
Yeah, there's no surprise that this has been debated in the literature for the past 15 years, so why do some patients tolerate indirect decompression, and why do some not? So we'll have to continue to work to try to answer that question.
One follow-up question, a lot of these patients, they wake up and have some amount of radiculitis. What is your threshold for following these patients out, and when you offer revision decompression, if any? Is it patient dependent? Is it neurologic deficit? I mean,
that's a great question, and this speaks to what you alluded to at the very beginning of the discussion. Is it's a tremendous leap of faith, and when you have that patient who's calling you in the first 3 to 4 weeks after your operation with some either residual or worsening or even new radiculopathy, it can be really unnerving. And I probably have taken a few patients back a little early. I think now these days I try to get them through the first couple of months. I do the old gabapentin, Lyrica. I've probably tried a transforaminal here and there, but it can be really nerve-wracking. The one patient that I showed with the L2 to S1, he developed a new foot drop, and I figured I had no choice but to take him back then. He was a little upset. He's doing great now, but then again, to be fair, you've probably seen this too. I have several standalone ALIF patients who have no persistent stenosis, who have foot drops just from the traction of the height restoration. So it's hard. It can be really hard. But these days I've gotten more comfortable in letting the patient wait it out a little bit, and I usually give them 2 or 3 months at least. What about you? What do you do?
Yeah, I think that's pretty reasonable. I try to give it about 2 to 3 months. We use the gabapentinoids, done a few injections as well. My threshold for imaging is fairly low, and I actually tend to worry about some of the osseous stenosis. So I might actually get an early CT and just, if somebody has persistent pain, and see if there's any residual bony stenosis or whatnot. And that might give me a little more confidence to wait. But you're right, several standalone ALIF cases, just by reduction or height restoration, get a traction injury, and you just kind of have to wait and have faith. So I think your point is well taken. I think as you see more of these do well and have the faith to see that although the patients are struggling early on, but there's resolution, and you're minimizing some of their morbidity, I think that gives you confidence to apply it to other clinical scenarios as well.
Well, that's awesome, Ray. Those are great cases, great discussion. I look forward to continued discussions with you in person once we can all get back together again.
Yeah, thanks for taking the time, Alex. I appreciate your insights, and stay safe.
You too. Dr. Hay, we'll throw it back to you. Thanks.
Well, gentlemen, I think you've done an excellent job of getting to the heart of the matter. And so I'd like to step back for an overview of this. I, too, believe in indirect decompression. Personally, I've had an L3 to S1 indirect decompression in PERC screw fusion with a good outcome. But that's not to say that all the patients qualify for that. So one of the issues is, how do we measure outcomes? And that was discussed a lot in this. Do we measure outcomes by length of stay, blood loss, return to work? Do we look at the early outcomes, that is the outcomes for the first week, they use less narcotics? Do we look at the intermediate outcome at 3 months afterwards? Do we look at the long-term outcomes at 1 year and then the durability of those outcomes down the road? What's also interesting is they chose different patient populations. If you chose Alex's first two patients, 43-year-old female and 72-year-old female, they each had single-level disease. If you look at the rest of their spines, they were pristine. So the 43-year-old nurse that Alex did with the slip and stenosis at single level at 5-1 did very well. The 72-year-old female, he hit it out of the park. That was a home run for L4-5 single position lateral and PERC screws. If you look at some of the cases that Ray showed, they're a little more complex, right? They have a little bit more deformity. Their coronal and sagittal balance was out a little bit more. He had CAT scans showing large hook and claw osteophytes. And these gentlemen discussed that. So again, it's not a one-size-fits-all here. I would think in there that we put multi-levels. Why is that? When you start getting into multi-level disease, it can hit the root at different areas. It can hit the root before the foramen, at the foramen, post-foramen. It's a little more complex on how multiple levels of roots can get impinged when you have multiple level disease. I think if you have single level disease, it's probably a more reproducible outcome if you choose indirect. I thought these young men did a phenomenal job, and I'm anxious to talk to them in person. Thank you.